We have a quorum, and it is the appointed time. Let me call the meeting to order. Shall we invite the deputations to come in, please?
早晨，團體啲房好遠㗎。
佢其實喺1樓嗰個喺即係個會廳嗰度等嘅，會廳嗰個係壁 gallery 嗰度，所以仲需要少時間先係咯，所以要
應該早啲嘅，係
咯，
明白。咦，好少你出席嘅，好少，好少出現喎，係咪得3個團體出現？哦，仲有嘅 ，OK。好，早晨，各位同事，係我哋。
Good morning. Good morning. I call the meeting to order. This is an 8:30 meeting. Thank you for coming so early. After this, we will have the budget. Today we are talking about mental health case management. This was started by the Hospital Authority in 2010. In the past, we did not have case management, so there was poor coordination. Now that we have case management, I believe it is something good. It represents some improvement. With regard to cooperation between the community and the hospital authority, and also the integrated centers for mental health rehabilitation support, is it that we can now have seamless coordination between the community and the hospital authority? This is the topic we'd like to investigate into today. We welcome the deputations. The administration has also prepared a PowerPoint presentation to introduce the case management system. First of all, we will ask the administration to do the presentation, and then it will be the time for deputations to speak. And then the floor will be open to members. Shall we now invite the administration to introduce the case management system? Dr. Zhang, I will ask Dr. Chong to introduce to us how we take care of mentally incapacitated persons, particularly case management. Dr. Chong, please. Dr. Chong. Chairman and members, let me now introduce to you how we deal with persons with severe mental illness or SMIs. Later on, Mr. Fong of the SWD will also talk about social services for SMIs. I have prepared a few slides so that apart from the paper submitted, we can allow you to know more clearly how we arrange services for SMIs at the HA. Overall speaking, we follow the international trend. We hope that MIs can integrate into society and receive services in the community. This is very important for their rehabilitation. In this slide, you can see that the number of people we are taking care of are about 195,000, and they are separated into SMIs, and about 45,500 belong to the SMI group. This is the figure for 2012-13. SMI, severe mental illness, is usually about schizophrenia and serious depression or other emotional illnesses. These are SMI categories. At different stages, SMIs need different kinds of treatment because they have different needs at different stages. Overall speaking, therefore, we arrange different services for them. Like in the first stage, we have EC for psychosis. This is the first 3 years when they become ill. And we know that some patients need to be hospitalized, so we have inpatient service. About 5% of patients will have to receive hospitalization. After discharge from hospital, or if they do not need hospitalization at all, they need community psychiatric service. There's a three-tier system here, and I will talk about the structure in a moment. Some other members, before they become independent of CPS, we have provided the MHD Direct. This is the telecare service, and I will again give the details in a moment. Some patients may need day hospital service. They need to receive training there so they can live independently in the community and maybe able to get a job as well. This is what the day hospital does. And about 30% of patients have rehabilitated quite well. They may be working. They only need special outpatient clinic follow-up service, and they just need to take medication on a regular basis. This is the SOPC. The call center is open 24 hours round the clock to provide support as well. Let me now talk about the three-tier community psychiatric service model. This is the CPS. At present, basing on the risk and needs assessment of the patient, we'll assess the situation and we separate them into 3 different tiers. On the right-hand side, you have the high-risk group. We will have the intensive care team to provide service. At present, we provide intensive and personalized care for high-risk patients. This is to provide support for them in the community. At present, we can handle 1,000 patients. In the middle, this is what we always mention. This is the PCP, case management. Sometimes people say this is a case manager kind of scheme. As the chairman said, this was started in April 2010. There is the service now in 15 districts. We expect to expand the service to cover all 18 districts next year, depending on funding support. At present, if we can reach 18 districts, we can benefit about 17,000 patients. This is a service provided by case managers who are experienced social and community nurses, professional social workers, allied health professionals, etc., so that we can support SMIs who live and receive treatment in the community. This is a kind of personalized service. Next, another tier for low-risk patients. This is the standard CPS. This is provided by community nurses. Patients who are discharged from hospitals may comparatively be stable. However, they need to go through an adaptation period when they return to the community. And this is the kind of service to help them adjust to life in the community. That's it for CPS in 3 tiers. Next, a relatively new service, the 24-hour Mental Health Direct. This is a hotline for the sake of mentally incapacitated persons. The hotline has always been there. It was at Castle Peak Hospital, but it was of a smaller scale. It was not very systematic either. Now at Kwai Chung Hospital, we have set up this 24-hour hotline serving the entire Hong Kong public. It is manned by professional psychiatric nurses, and support is provided by the computer system. There are 2 parts to the service. One, advisory. This is provided round the clock. In other words, patients can always call us up to get the service. And we are now also developing the telecare service so that we can interface or dovetail with case managers. The case manager might have seen the patient for 1 or 2 years and the patient is all more or less stable. But the case manager may not be totally confident that the patient can become independent right away. Telecare service will provide the support that the patient needs before he fully integrates into society. This is a new service. Next, I'd like to defer to Mr. Fong of the SWD to talk about other community mental health support services. In the area of social service, there are 2 scopes. One, medical social service. In psychiatric hospitals or in day clinics, we have medical social workers who work as part of the professional team who will formulate discharge and rehabilitation plans.
We will also discharge the statutory duties. For example, according to the Mental Health Ordinance or the Protection of Children and Juveniles Ordinance. So basically, we are performing our services at hospitals. Our clients are the patients and their families. In the community, we have a integrated community center for mental wellness. We have 24 such centers in the territory to provide one-stop district-based and timely mental health support services for those patients who have been discharged or those who are on rehabilitation. The target clients are those over the age of 15. But if their families encounter any difficulties, the center will also provide services to them as well. So that basically would be the two major services provided by the welfare sector. If I may now next talk about the collaboration platform between the medical and social sectors. I think we all know that the cross-sector communication is very important for community psychiatric services. The medical and the welfare sector needs to work very closely together. And because of that, the collaboration, we've built up a three-tier communication channel between the medical and the social welfare sectors to ensure that our services could be better coordinated. At the top tier, we have a central coordinating group. At the headquarter and policy level, we will map out the direction for the overall provision of community psychiatric services. Basically, the group is chaired by representatives from the Hospital Authority and the SWD, and so at the policy level, the CCG will map out the overall direction so that we can have better coordination. At the community level and at the district level, we have the so-called DPGs or district task groups. The tasks, there are 11 such task groups in various districts. They will focus at the operational level. That is, how can we ensure that there can be better coordination between the two sectors? And we have representatives from the of the HA Psychiatry Service from the different clusters. The chairman of the task groups would be the district welfare officer and also the head of our psychiatric service at different clusters. The work undertaken at this level is more extensive. Other departments, such as the police, the housing department, would also participate in the work of the DTGs to ensure that the service at the district level could be provided smoothly. At the lowest level, we're talking about case management. At the local level, we have a mechanism for communication. Basically, we have a community psychiatric team and also the ICCMWs, that is the Community Center for Mental Wellness. At this level, we would discuss interface involving particular cases and also how complicated cases, how we can intervene for complicated cases. I think that's all I would like to say. That sounds very, that sounds perfect. It would appear that we are having a seamless, collaboration between the medical and the welfare sector, and we have different tiers of communication channels. Let's now listen to the deputations today. I'd like to welcome all the deputations for coming to join us in our discussion. I'd like to remind you that your speech will not be protected by the Legislative Powers and Privileges Ordinance. Given the number of the deputations, I think I can allow 4 minutes for each deputation. I hope you also focus on our topic for today, which is mental health case management and community care. So we will start, first of all, with Caritas Hong Kong Wellness Link, represented by Mr. Stephen Wong. Good morning, and I'd like to thank members for inviting us to attend this hearing so that members can listen to our views regarding community care. Recently, the HA and the SWD have done a lot of work, especially in enhancing community care for mental patients. There are also new initiatives being developed. We believe that this is a good sign. We've also said, well, I think the scheme has been running for a few years, and we'd like to simply highlight a few concerns on our part. First of all, the HA and the SWD, when they developed the case management, they developed a case management system for very different reasons. For the HA, they are basically focusing on the patients with SMI, whereas the SWD does not have any plans targeting at SMIs. So there is a difference in terms of the direction by which they develop the service. The HA has made some pledges. That is, they suggested that the case manager should cater to 50 patients, but there is no such limitation on the part of the SWD. That is a single case manager. There is no restriction on the number of patients which a case manager would need to look after. So this is where the two differ. Recently, I think the case management system is a good system because the clients and the values may be different. Well, mental disease is a chronic disease, especially for serious cases. The patients require long-term care. But given limited resources, and we would like to follow up on the patient during the adaptation period, which will last probably only for a year or two, and then we'll close the file, so that we only reactivate the case when a problem arises later. For long-term care, we don't know what. No, we wonder whether we should have a plan for the long-term follow-up service for these patients. As in the case of other chronic patients, we have long-term follow-up measures to take care of the patients. And secondly, in terms of staff recruitment for both the HA and the SWD, the NGOs are encountering many difficulties. We're happy to see that a start has been made. The HA basically are focusing on the SMIs. We don't know whether or not we can also look after patients with emotional problems, and if so, when are we going to start? When will we start planning for that, so that we can work in tandem by way of manpower training? Overseas experience in Europe, Australia, and the States have shown that peer support is very important, especially the policy in Australia. 30% of the mental health team should be peers of the patients. But in Hong Kong, we have a shortage of manpower. There's a shortage of professional staff. In terms of development of peer support, I wonder we should have a plan. Recently, a few NGOs are starting to recruit, peer support personnel. We believe that in each mental health care unit, if we could have two such persons helping, implement the case management effort, it would be better. Next, we have Ms. Lai Chi Shan. I'd like to thank Ms. Chen Yun Han. In 2007, I was suffering from cancer, and she helped me change from working part-time to to working part-time. At the office, I was constantly being criticized by my peer colleagues. When I complained to my supervisor, he asked me to sign a document a week later saying that the matter has been settled. But he actually have not done anything. I hope members can help me liaise with my supervisor so that I can have a job transfer, because my health is deteriorating every day. I don't really want to stay in this rather complicated working environment. In the final stage of my life, I would like to, spend the rest of my remaining days in dignity. And I don't want to rely on CSSA. I like to, survive the rest of my time independently, because I'm now suffering from a relapse of my cancer. So I think we can make some arrangements after the meeting in respect of your conditions. Do you have any comments in relation to the case management model? I've been under a lot of mental pressure, and I have to go to the psychiatric clinics to obtain, sleeping pills. Otherwise, I wouldn't be able to work, and I have to work the night shift, on an extended basis. Ms. Lai, I think we can deal with your case after the meeting. Next, we have Mr. Wong Kwai Sung. First of all, I'd like to thank Dr. Tsuen for Dr. Tsuen. In 2012, you challenged our company for overworking our staff. There are many cases of mental illnesses in our company, like the lady next to me. She actually, report for duties punctually, but the company did not give her an award, any award for good performance, because she is ill. I think the situation in our company is out of control. For example, what it says here, all of us follow the rules, and we can, work in a safe environment and so on. And, code of conduct, occupational health and safety and so on. Mr. Wong, to let full and part-time staff understand the policies of the company and the local legislation, but the company is saying one thing and doing something else. We feel that this is really very confusing. So how should we put it? I beg your pardon. I think I have an infection in my throat. Mr. Wong, if you'd like to talk about a particular case, we can deal with it after the meeting, but I would like to ask you to comment on the case management system. Well, yes, exactly. We're seeing our patients getting sick one after another, but the management of the company is only, putting up some making some token gestures. Nobody is coming to work, and only 1/3 of the workers are reporting for work, and the company talks about occupational health and safety, but nobody is reporting for work. Myself and the lady are contract staff. I think we can discuss the working conditions for staff working the jockey club on a different location. I would show you by way of the CD-ROM the condition of the environment in which we work. I understand that Mr. Teng Ka Pio will be urging the administration to enact a piece of legislation in July. I hope the legislation can be enacted, before we passed away. Next, Mr. Chen Kwok Sing from the. Good morning.
Before I talk about case management, let me talk about history. Why do we have case management? This has been copied by Hong Kong from overseas, but we have only copied half of it. We did not copy the resource part. Secondly, in overseas, they are called consumers, but in Hong Kong, we are service users. When you are a consumer, you can deploy resources and you can have a choice. But in Hong Kong, you can only receive the service that has been dished out to you. This is the first thing. Secondly, in other places, case managers only manage 10-odd cases, but in Hong Kong, 50. That's a big difference. Let me talk about my own experience. I have used the service of case managers, but what they helped me to do was to count my medication and also deal with my relationship with my family members. If I want to have activities, they introduce me to ICCMW and nothing else. But in my mind, a case manager should do more at the level of the Bureau or the Labor Department, SWD, or even Education Bureau, Hospital Authority. They should do the coordination role or should have an influence. Sorry, I left out the Housing Department. That's very important. We also have a big housing problem. I hope they can play a coordinating role. This is the first thing. Secondly, I hope they can help us deal with our emotional problems. In other places, case managers don't only help you get a job. They also help you deal with your emotional life. This is the second point. Number 3, I hope they can explain the rights and responsibilities to patients. In terms of rights, if you're a Hong Kong citizen, you have certain rights. And as to responsibility, say your family status, if you have siblings and parents, you also have to take up the responsibility. Actually, many patients don't understand all these. I think I'll stop here. Thank you. Thank you, Mr. Chen. Let us go back. Civic Party. Ms. Bonnie Leung. Thank you, Chairman. The Civic Party is of the view that mental illness is a serious problem in Hong Kong, but all these years there has been insufficient support provided by the administration. There are 334 doctors, but we have 195,000 patients. In other words, each doctor has to take care of over 580 patients. There is only one psychiatric doctor for 22,000 people in Hong Kong. In the US and Australia, they have one psychiatric doctor for 6,000 to 8,000 population. The WHO standard is that there should be one psychiatric doctor for 10,000 population. Therefore, now people have to wait over 100 weeks to get the service, but the patients are given only 5 minutes at consultation. And after discharge, they need to face a serious lack of care and treatment. There are 40,000 SMIs who need to be followed up after discharge. Starting from April 2010, case management has been rolled out, but there are the services only in 15 districts, and only in 2014 policy address it is proposed that this will be expanded to the other 3 districts. And so you are not meeting demand. We propose first to increase resource and also shorten the queue at outpatient clinic and also give more time at consultation. There should also be night service. There should also be more resources to employ medical social workers, community nurses, and other allied professionals. There should be better training so you can provide more service. Number 3, you should deliver your promise and to perfect the ICCMWs and find permanent addresses for them. Number 4, public organizations should employ certain numbers of handicapped people, including SMI rehabilitated persons. And number 5, there should be more public education and allow the public to understand mental health more so that there would not be so much discrimination towards the patients and rehabilitated persons. In fact, the Civic Party has proposed these to the administration time and again in the past. I hope you will listen to us and also the views of other deputations and implement them. Thank you. Thank you, Ms. Leung. Next Concord, Mr. Lee Chi-on. Good morning, Chairman, members. Many patients and many of my friends live alone, and their problem is a lack of support and care. There are ICC MW case managers or social workers visiting them regularly, but by that is meant once every month or once every 1.5 months, and it is just a 30-minute visit. I don't know what care can be provided for the patient in those 30 minutes. They may ask you, are you eating your meals? Do you get home care? But after those 30 minutes, can the patient get hold of these professionals if they fall sick or are in need of care? In the end, there is only self-help. There was a patient who fainted at home, and it was good that a friend found this out after 3 days and he was saved. If he was not discovered after those 3 days, I don't know what would have happened to him. There are many such examples. Patients had accidents at home or fainted for other reasons, but they were not discovered and therefore were not saved. We don't want to see more of these cases. But I don't know what councillors and the ICCMWs are doing. If they really care about us, you wouldn't allow the situation to deteriorate to such an extent. I hope you will really look into the operation of ICCMWs. Thank you, Mr. Lee. And then Mr. Hui Wai Chun. Good morning, Chairman and members. Talking about a service, we need to set a target and then we can assess whether it is successful. The policy paper says that this is a service to help the rehabilitated persons reintegrate into society. But have you assessed your work? I am a frontline medical social worker, and I think you are not achieving your target of integrating patients into society. Just like what Mr. Lee of Concord said, usually they live alone. They recoil from meeting people. They do not have many relationships. They do not have work, so they do not have support. I think you should take a frank look at the problem. Our service is just to get patients into hospitals when they need it. But what I mean is, you should provide help at an earlier stage. What we are doing is for neighbors and social workers to discover the patients and send them into hospital. And one case manager has to follow up 50 cases, and there is a visit made to every patient only once a month. So we need to take a closer look at the problem. Your figures and charts may paint a rosy picture, but in fact, you are just cheating people and yourselves. So first of all, you need to be honest about the situation. If you're talking about integration into the community, you need to set indicators and yardsticks. You may measure the number of friends they have, whether they know how to seek help, and how their relationship is with other people. And then you can say, by adding how many people, we can improve the achievement of these indicators. Or else this is just empty talk. Secondly, there is no cooperation between case managers and ICCMW social workers. Yes, meetings are held and there is discussion on certain cases, but each tends to work alone. As Mr. Wong of Caritas said, ICCMW deals with a whole stretch of cases, from even suspected cases to serious cases, but case managers only take care of SMIs. So there is a small overlap only between their portfolios. Can we introduce the concept of step up, step down? If it is right after discharge, then it should be followed up by ICCMW. You must set a protocol of care. Somebody has to be the coordinator or the leader in a team of professionals, or else doctors won't know what to do. It seems you tell people there are these two services, and on the face of it, two teams are helping the patient, but after a year, both services will be cancelled. We need better cooperation. You need to really draw up a mode of service, and then you need to complement this kind of service. One social worker cannot take care of all the problems of rehabilitated persons. You, for example, should provide cleaning services and meal on wheels, and maybe one-stop service, and particularly crisis support. Don't just send everybody into hospital. If there is a crisis, they should be able to go to a crisis management center first. This should be a multi-tier support system. You should design your service like this, and only by so doing, case management will be meaningful. Thank you. Mr. Tick Kwok Fat. Thank you, Mr. Chairman and members and officials. I am a rehabilitated person. I also work as a volunteer in a self-help group. I am also the vice chairman of that group. This is the first time I have been to LegCo to speak. This is about mental health case management. After listening to deputations today, there are service providers here and also self-help groups here. I believe we have rehashed the same problems many times, and I'm sure smart officials know these problems inside out. Since we face so many problems and they have not only arisen today, so should we tackle them? Should we tackle them immediately, or should we tackle them in a delayed manner? We have heard that with regard to depression, of course, it's a psychiatric illness. It will become the most serious illness affecting the most number of people in the future. The psychiatric illnesses can hardly be quantified. As you know, even people who are not ill may have emotional problems. Now, this kind of illness is different from other illnesses. Other illnesses can somehow disappear. They can, let's say, self-destruct. But this kind of illness is such that someday other people may get hurt because of such illnesses, and the patients can also hurt themselves as well as hurting others. We can subscribe to what the administration has done, but as other deputations have said, you may be duplicating your services in certain areas. Now, how did case managers come around? Some people have lost their lives because of these illnesses, and other people have been hurt as a result. So the administration dumped money so as to drown the voices of the public, saying that they have done something already.
Case managers work on these cases, so do the rehabilitation nurses. The ICCMW are also doing their part, so do the social workers. Very often the same client is being served by these different parties. So I think we should streamline the allocation of resources which are needed to help these patients. We see that the number of patients are now increasing, but the government has not considered how we can, consider, how many patients can we cure, because the number of patients keep increasing. If you could cure one patient, you're helping not just one person, because their families, the community will be in a more stable state. They will not be affected by the emotions of this patient, and all the necessary worries and concerns and nuisances could be removed. Sorry. Thank you very much, Mr. Tick. Next, we have the Richmond Fellowship of Hong Kong, represented Mr. Terry Wong. Thank you. The Richmond Fellowship operates ICCMWs in 2 districts, in Mount Tai Sin and also Island East. In these 2 districts, they also have the PCP project, Island East in 2012, and in both districts, cases have been referred to our ICCMW, but the approach adopted by the 2 districts are slightly different. On Island East, they don't work with the ICCMW. There are no joint case conferences, whereas in Mount Tai Sin, they have case conference meetings every month. We hope that there could be regular meetings so that there could be better coordination. In terms of case referrals, our colleagues at the PCP will refer cases to the ICCMW. The PCP may only follow up on a patient for a year or 2. The ICCMW will then take over such cases. The ICCMW is in a more passive state. If the ICCMW suspect of certain cases, they cannot refer them back to the PCP. So there might be room for improvement here in terms of coordination. And secondly, the PCP will refer cases to the ICCMW, as the latter will provide a catch-all service. But the ICCMW do not just take over cases from the PCP. For minor cases or suspected cases, the ICCMW also need to take over such cases. So it's not just for our 2 districts. The similar problem may be found in other districts. So the number of cases are increasing all the time. So I hope the government will review whether the manpower resources at ICCMW are sufficient. If there is no limit to the number of cases that they are required to handle, then we will be working a lot of pressure. Some deputations already pointed out that some ICCMWs don't even have their own premises. We are more fortunate. We have the support of the community. We're able to operate our own, center. In the absence of any premises, it will be difficult for these ICCMW to operate. The manpower situation is also very tight at these centers. We hope the government can review the situation. Perhaps, right now a case manager will take care of 50 patients, but there is no such, quota for the ICCMWs. In terms of resource allocation, the PCP has more resources allocated than the ICCMW. We're not saying that we are asking for fair treatment. But then if both parties are follow up on on these cases of SMI, I think there could be a more balanced, allocation of resources. On our part, there is no time limit for the cases that we follow up on, so we could follow up, on a patient throughout his whole life. So I think we need a timely review here. I'd like to thank all the deputations for expressing the views. We may now give some time for the administration to respond, especially whether the administration could give us the overall picture that is for patients with SMI. So I think what is the division of labor between the PCP and the ICCMW, the manpower allocation? In some ICCMWs, they don't even have their own premises. There are 24 teams. How many of these teams don't even have the premises? And how do you propose to resolve this problem? And some deputations mentioned the question of manpower shortage. I think this applies to both. There is also a manpower shortage of psychiatric staff at the HA. Some deputations mentioned that there is a lack of resources for peer support, and also the question of recruitment. Could you give us a global response? Thank you, Chairman. I'd like to thank all the deputations for coming here today to give us the views regarding our case study system. They certainly help us further enhance collaboration among the different parties. Many deputations are concerned about the case management at the working level. Case management, in fact, is one approach, and whether it's in the medical, and other social problems, resorting to case management approach to provide an integrated or comprehensive service is very common. For the patients with serious SMI, deploying case managers to help them is one such method. Under what circumstances do we need to use the case managers? First of all, there would need to be a complex need. That is, medically, we're talking about the clinical need. We also need to consider support at the community and family level, and the problems we need to tackle. So the case managers basically would allocate the case managers according to the complexity of the needs of the patients. Since they need different professions are involved, and they need to provide services to the patients in order to avoid duplication of effort. We need to have a better coordination method, and therefore case managers can help us better deploy and resources. Thirdly, the cross-sector and cross-discipline approach. Other than medical staff, the SWD and other Caritas have different responsibilities. So that's why we're using the case management approach and case manager to deal with these cases. And it's not true that a case can be can be handled in a year or two. We would distinguish patients into high risk, medium risk, and low risk categories. For some patients whose symptoms may have become stable. When they reach a certain stage, we will provide them service, relevant to that stage. And Dr. Zhou already told you how we serve patients who are categorized as high risk, medium risk, and low risk. So we need to look at the entire mechanism. After a patient has recovered to a certain extent, or if their conditions has deteriorated, then we need to provide him with different services. The important thing is extended treatment. How can we ensure that ensure that there's. So other than case managers, we also have the outpatient services and the day hospital services, and we work with the different organizations. Some deputations mention the need of coordinating with the ICCMW and the SWD. Of course, there's a lot of room for improvement. Most importantly is the case conference. For individual patients, focusing on the symptoms of the patients, we need to have a case conference so that together we can jointly discuss what are the problems confronting this patient and parties should offer the support. And the case conference therefore plays a very important role in the course of the treatment of the patient. Some deputations say that there is a lack of coordination, and we certainly go back and review this further. Next, the question whether or not services are inadequate and there is a long waiting time. First of all, manpower. Obviously, there is an insufficient number of psychiatrists and psychiatric nurses. Even a case manager, there is a shortfall of 60 such case managers. We expect that by 2015-2016, the vacancies for all case managers could be filled, because every year the newly graduated, the number of psychiatric nurses and who graduate exceed 100. So I think that can gradually help fill the gap. Regarding the waiting time at the OPD, outpatient clinics, for the outpatient psychiatric service, the median waiting time is 5 weeks. More than 90% of the for 90% of patients, waiting time could be up to 9 months. Of course, the shorter the waiting time, the better it is, and we agree. The message here is that for the majority of patients with SMI, after they've been gone through the triage arrangement, they would be able to get treatment in 5 weeks. Those who have to wait for longer are patients with milder symptoms of mental illnesses, and they're not urgent cases. For urgent cases or the more serious cases, the waiting time is not really that long. For the ICCMWs and how they interface with the PCP and how they make referrals to each other. This is being done in different districts, where if certain districts are not doing so well in this regard, we can certainly review the situation with the stakeholders concerned. The PCP, if they discover the patient has a problem, they can refer to the ICCMW and vice versa. With that, perhaps I can now defer back to Mr. Fong, who explained to you what the SWD is doing. Now, first of all, the ICCMW. Many deputations mentioned the lack of premises for some of these centers. For ICCM, there are 10 ICCMWs with permanent premises. There are 7 for which the premises are being fitted out. For most of them, by 2014 to 2017 to 2018, they should be able to start providing service. For another center, we already found the premises and we are going through consultation. There are 5 such centers for which they have yet to find permanent sites or premises. For these 5 centers, they are now leasing industrial units in industrial buildings to operate the service. They could also be making use of some of the former halfway houses. Perhaps I can give you some more background here. In 2011, before we launched the service in October that year, our decision then was to extend the scheme throughout the entire territory of Hong Kong. We anticipated it would be difficult for us to find premises for these centers. I remember I also took part in making the decision. We talked to the service, the users and the government. The SWD has undertaken that we would find premises for these ICCMWs. However,
why did we make that decision then? It is because we did not want to open one when we could find premises for one. This is about an overall of the service, and we believe that may take 10, 20 years. At that time, we made the decision amidst very difficult circumstances because we hoped that we could put more pressure on ourselves and our colleagues to find premises. We have operated it for 3 years now, and in fact, we have found many premises. So it was a well thought out decision, and we promise we are going to look for permanent addresses. And in the interim, we'll continue to subsidize NGOs to rent commercial premises. In the entire process, we have worked out of the box. For example, if we leased commercial premises, there were many policy constraints. But when we rolled out the ICCMWs, we have already surpassed those barriers. In some premises, the rent is over $100,000, but we think the money should still be spent because we should allow the service to reach rehabilitated patients as soon as possible. I hope you understand our difficulty, but we promise we'll continue to do this. Secondly, case management and so-called underwriting. We understand that the precedent of the ICCMWs served different kinds of patients. In fact, suspected patients were a difficult group. There were no dedicated personnel to take care of them. The police, the housing department would refer these cases to us. But the service was not coordinated. We felt that there were service gaps. We therefore consolidated the service also to serve suspected patients. When I talk to frontline colleagues, we think that it is very difficult to get in touch with these people and they may not cooperate with you. It is only when a crisis happens that they would be happy to cooperate with you. I really like to thank our colleagues at ICCMWs because they have spent a lot of time to build relationships with suspected patients. We need social workers who will serve this group of people as well, or else they may prove to be time bombs, as many people say. Talking about manpower, mental health cases are difficult cases to handle. This is not argued at all. If we have social worker figures, I can tell you that each social worker would be taking care of 43 cases on average. If we include therapists and other people, then the number would be 36. Whether it is 43 or 36, there is not a lot of meaning because the complexity of cases can mean a lot more time or less time. We understand the pressure of our colleagues, and that is why the PA says that there would be more resources for ICCMWs. We have also promised to NGOs that when we have done with another injection, we will again take a look together with the HA to gauge the effectiveness of the service. By then, we will be able to have a clearer view and to see what improvements can be made. And talking about manpower, I believe in the past few years, it has been difficult to recruit for any service at all. In the social service area, let me talk about our therapists. We have spent tens of millions of dollars to open 2 classes at the Polytechnic University. The first course saw graduation in January, turning out 59 graduates. They have received scholarships from the SWD, and they have given the undertaking that they would work in the social welfare sector after graduation. They have done so, and the second class has started with 57 pupils. By the same token, we'd like to train psychiatric enrolled nurses. Starting from 2008-09 to 2017-18, there will be a total of 360 psychiatric enrolled nurses to be trained. Again, they have to promise to work in the relevant sector. In the past 6 years, 240 graduated, and we expect 120 to graduate in the next 4 years. We hope that would provide some kind of relief to the manpower situation. We understand that the Bureau Secretary, Mr. Ko, is heading a committee which is looking at overall manpower requirements in terms of nursing, care, and other kinds of treatment. We hope we will be able to meet the ever-increasing demand for services.
I'd
like to thank the deputations, and also as the HA mentioned, there is a coordination issue between the community and the ICCMWs. As has been said, there is a multi-tier system, and we have meetings in every district headed by the social welfare officer and involving the heads of psychiatric units at hospitals. We discuss operational issues, and some of those have been resolved. We expect such coordination meetings to be useful, and they are held 2 times or 3 times a year. But we face a plethora of problems, and we need to always have an open mind. I mentioned case referral. At the ICCMWs, we have a manual for case referral with the HA. If rapid changes happen to a certain case, we will have to see how we should deal with it. But indeed, there is a protocol for doing so. But you must understand that the reform has been with us only for 3 years. I hope you will give us some time, because we are still finding the best way out. I hope we can always further improve services. That's my response so far. Thank you very much. As the chairman, I have heard very different voices on my 2 sides. From the community, we see a lot of gaps, and it seems that you are just tackling the symptoms of the problems. But the HA and the SWD have painted a very different or ideal picture. Now the floor is open to members. I have many questions myself, but I will allow members to ask questions first. 5 minutes each. The order is Chang Kwok Chi, Joseph Lee, Poon Siu Peng, and Leung Yu Chung. Mr. Peter Chang. Thank you, Chairman. I thank the deputations and individuals for coming to the meeting. You are at the front line, and only you can have first-hand experience of the service. Just now, with Mr. Wong Man Shun, talked about the predicament affecting ICCMWs. Even if the administration says you are underwriting the service, and you say it is not that bad, one social worker with 43 or 36 cases, but the pressure on colleagues is so big. I believe you have these figures, 43 or 36, you're just playing a game with figures. What do you call a case? When will a case become a case? As many colleagues said, a case for 1 day will be a case forever. When will you regard a case not as a case, so it is deleted? So you have rather good-looking figures, and it will be lower than the 1 to 50 of PCP. I think we need to take a closer look. Mr. Chen Kwok Sing talked about his expectations on case management. Dr. Tsuen said a moment ago, you have a definition for case management, but in fact, the users of the service, or let's say the customers instead of users, in fact regard it in a much wider scope. You would want to get in touch with the case manager for anything you need. And also, the case manager should get in touch with you even if you are progressing well. I can give you an example. A rehabilitated person may be a university graduate and he wants to work, so he gets in touch with the case manager. The case manager will say, okay, go look for a job. And he says, I can't land a job. And then they say, you should get training from ELB, but I'm turned away because I have graduated from university. And you need to go through certain procedures. You need to talk to the ERB so they can relax the criteria. In other words, you are a rehabilitated person, you are a graduate, and you can still read some courses. I believe such communication should take place, and the patient would like that to happen, but case managers only looks after medication. In other words, the case manager only intervenes when there is a problem instead of really managing a case. In fact, patients expect care as well as problem solving, help. In other words, your definition should not just be limited to regular taking of medication. I believe you should communicate more on the definition. And then another deputation talked about cooperation between the community and the HA. I think we are both doing this, but we have different rationale. On the one hand, you say it's all right if the problem is kept under control. On the other hand, people are talking about community education and also caring for suspected cases. You may be going in the same direction, but as Dr. Tsuen was saying, you are very happy to discuss cases, but what about community cooperation? This kind of division of labor is not facilitating cooperation, and that should be improved. All in all, perhaps we should look at this from the point of view of case management and what quality of case management we need. There is not a lot of time, but can somebody please respond? Dr. Tsuen? I agree. I agree with what Mr. Tsuen said. What we need is not just case management because it cannot resolve all the problems. We need a whole system, a social system that can help rehabilitated patients. We shouldn't just go for case management and require it to resolve all problems. I don't think that can be done. Case management is just a tool for us to face certain problems, but we need a social system. So we can regard this in two aspects. We can continue to do research with the SWD, and there will be some landmarks. First, we have commissioned the Hong Kong U to do research for us. They are doing it. It will conduct research into this first stage of case management policy. In 2014-15, this will happen in all 18 districts. And by 15-16, there should not be any lack of manpower. In other words, no vacancies will be there. And then we can review it with the SWD. And secondly, Mr. Koh is coordinating mental health care. We expect a blueprint to come out from that committee's work. Mr. Fong.
Thank you, Mr. Tsuen. Regarding the number of cases, let me make a supplement here. The so-called average number of 36 or 43 cases We are dividing the total number of cases we handle by the number of staff. Of course, in different districts, there might be variations. We need to work on many cases. If we can maintain the average workload of 30-something or 40-something cases, it's already not easy. If we have a large number of cases, the staff, the colleague concerned may not have to work very hard. Only those who work very hard may maintain a small number of cases, because some cases may have concluded and then there will be new cases. So those two figures do not really have any significant meaning, but rather the complexity of each case is something that we should look into. I think the more I listen to the response, the more confused I am. On the one hand, you tell us that the figure is only for reference, and it doesn't reflect the workload of the staff concerned. In that case, we may need to look for other indicators. Dr. Joseph Lee, thank you. Today is a good opportunity because the Bureau, those who are responsible for policy formulation of the Bureau, can come here and listen to our deputations who are the so-called clients. If you look at the PowerPoints, you have painted a very good picture. As the chairman said, you seem to be providing a seamless service. Then it would appear that there's no problems at all. I think this is inevitable, because what you're doing is armchair management. But when the whole scheme is being implemented, we are encountering all these difficulties. So today we need to really consider whether or not you need to make some improvements. Case management is something new. We're talking about a whole person, caring for the whole person. We need to provide the patient with, all direction care. Like Mr. Chen said, I don't just expect the case manager to help me count the number of pills that I'm taking and say I'm in fine shape today, and that's the end of the meeting. So other than referrals and coordination, where there is a question of whether we have sufficient manpower. Looking at nurses, for example, a patient can look after 4 patients, but now one nurse is looking after 12 patients. The director, well, never mind, the nurses only need to work harder. But then this is bad for the service users. They don't care how many patients the nurse will look after. And it really happens that sometimes the nurses cannot really, help them. The HA divide the patients into 3 categories: the high risk, the medium risk, and those who have rehabilitated. But the reality is they are not, stopping the queue. The so-called rehabilitated patients, we don't know whether they exist. So the queue is moving all the time. You have a large number of service users. The case manager will only, the number of patients keep increasing, and they sometimes will only, So are you assuming there will be no new cases? And if there are new cases, how can you really provide for this sort of seamless service? So if I'm ill and if my disease is not critical, then you will simply, pass me on. Or should you have a more comprehensive plan? Don't wait for Dr. Koh's manpower indicators. So you need to make the service users rest assured that if you go for community rehabilitation, you need a large number of manpower. The HA and the SWD, whether we're talking about the ICCMW or the CPC, there's a gap in terms of their coordination. Referral is a major problem. So I hope that through our meeting today, after our meeting today, you can go back and see whether in the long term you can come up with the plans to ensure that there is better coordination. And secondly, regarding the mental health ordinance, I think some of the provisions are already outdated and they are tying the hands of the case managers. There are certain things the case managers cannot do. So the selection of a case manager, I think there are people who are suitable candidates to become case managers. They're very conscientious. Given the constraint of the ordinance, there are certain things that they cannot do. So when they meet a client, he can help Mr. Chen count the number of medication, but there are things that he cannot do, and then you have to refer the case back to his supervisor at the center, and then refer him to a nurse. So I mean, these are matters of details, but such details would mean that the service user is having the impression that the case manager is not really being very helpful. So perhaps we can fine-tune the ordinance, provision the ordinance, and so on. I'm not suggesting positive or negative vetting here, but I don't think we should, waste this very good mechanism.
少少時間，張醫生係。
OK， 多謝李議員嘅意見。
Thank you, Dr. Lee. In 2015-2016, the manpower shortage will be filled. We're talking about the service area under the existing system, the gap of 60, a shortfall of 60 vacancies can be filled. I agree that whether we're talking about the aging population and the number of mental patients will go up because we get new cases every month, and the old cases it cannot doesn't mean that the patients are perfectly cured. So in the long term, we have a 5-year blueprint for mental illnesses. Regarding the manpower situation, we will certainly review the situation every year. Perhaps I can ask Mr. Fong whether he has anything to supplement. Mr. Poon Siu Peng. Thank you. I'd like to thank the deputations for coming here today to share with us their views. Having heard the deputations, my impression is that our service is not is lagging behind the demand. They've told us that in other jurisdictions, a case manager will only look after 10 patients, and while the officials told us that the number may not be very representative because the complexity of each case may be different. Although the paper tell us that you extend the case management system to all 18 districts, and you expect that the number of patients per case manager will be 27. We started this scheme in 2010. When you calculate the number of service users, I don't know whether it's reasonable because we have more than 190,000 mental patients. Is it because of human resources considerations, or is it because of other reasons that you have made this assessment of the number of patients? And how do you measure the efficacy and also the here? Although you say you've implemented the scheme and there will be a review later on, so do you have more objective criteria to help assess the effectiveness of this scheme? Dr. Zhang, thank you. In 2014-2015, the scheme will be extended to all 18 districts. As to whether or not we are able to serve 170,000 patients, and how do you arrive at that figure? And even if we're talking a ratio of 1 to 50, that reference number for, I like to explain that of the 190,000 mental patients, there are only 45,000 who are serious cases. Of course, there will be an increase in number every year. Among the 45,000, how do we decide whether to categorize them as high risk, medium risk, or low risk? We have a clear set of guidelines. We will consider, first of all, the clinical, the family, and the community support available to the patients. That is at these different levels. And also we look at the complexity of the case and then decide whether to deploy a case manager to take care of this case. So we're looking at objective clinical standards and criteria. So looking at the number of patients and we will follow the criteria. As to whether or not 170,000 is sufficient, this is only a target. Even the 1 to 50 ratio is only a figure in our plan to help us decide how many people we need to train and how we can deploy them to the respective posts in the next few years. So for the case managers, they handle different number of cases. On average, it ranges from 30 to 60. The number is based on the complexity of the cases. If the case is complex, it will handle a small number of cases. And secondly, the competency of the case managers. For newly trained case managers, they may not need to look after more complex cases. They will look after the more general cases, and they may have to look after a greater number of patients. So it's not 1 to 60 for all case managers. Every year we need to review the complexity of cases of the rehabilitated mental patients before we decide on the number of case managers we need to hire. As how we compare with other jurisdictions, I don't think we can make the comparison. The scope of service, the composition of our community are different, and so it's difficult to directly compare with other jurisdictions. How do you measure the effectiveness of the case management system? Well, we've only implemented the system for 3 years. We have some initial indicators, including the mortality rate, suicide rate of the patients, and the number of times they use the emergency ward, whether the symptoms have improved, the difficulties they encounter at the community level and the respective families, whether they're able to cope. So we have all these indicators which are still being assessed. That's why we've commissioned Hong Kong University to help us conduct this, to make this assessment. And we will have another major review 2 or 3 years later. That review will be undertaken jointly with the SWD. Dr. Tsuen, if you could have a paper, I hope you will also provide that paper to us. Mr. Leung Yew Chung, having heard the two sides, I find it difficult to understand why the services find there are so many problems. The service providers are claiming they're doing everything and offering, all kinds of services. So I don't know who is right and who is wrong. Superficially, it would appear what the government is claiming is that they are offering a seamless service. So what has gone wrong? Yes, it is true that they offer all kinds of services. They're doing everything, but they're not talking about quality. They do not talk about the quality of service they provide. That's why you have a problem. But the service users are more interested in the service quality of the cases that we've heard about. Yes, the patients are visited by the social workers, and they meet with the social worker once a month or a month and a half, and they only meet the meeting only for half an hour, and the social worker will only persuade the patient to take medication. The administration claims that it is doing something, but the service users are saying that that's not enough. After hearing the administration, my impression is that they're not focusing on the quality of service. Mr. Tek put it very well. He said that many patients, rehabilitated patients, want to be entirely out of the queue and be fully rehabilitated. But in order to do that, you need to offer him intensive care so that his symptoms will change from serious to medium or minor. But then if you do not focus on service quality, it may be the other way around. So in our discussion today, I think our discussion boils down to one point, that is, how do we enhance the service quality? You talk about the number of doctors. Dr. Tsuen, you show us some figures. You say this is only for reference. You say that the waiting time for serious cases is 5 weeks. For the serious cases, on average, is 40 weeks, the same as in 1994. I don't like these mathematical terms, medium, figure. What is the shortest and what is the longest waiting time? You never tell us that. The longest waiting time would be more than 5 weeks. It could be 10 or 20 weeks. I don't know, because you're not telling us. Do you understand where the problem is? You've only shown us part of the picture, rather than showing us the whole what the whole situation is like.
I teach mathematics, but I don't like these figures. You talk about the median, but the median means there is a range. You don't tell me the range. These are abstract things, and you are pulling wool over people's eyes. It seems you have told us you have done a lot. However, only the people who use the service will know how they suffer. When we have meetings here, we receive figures, but we are played around by these figures. The bureau, the departments always show us figures. And as Ms. Leung was saying, what are we complaining? We are complaining that, okay, the median is 5 weeks, but how long is the consultation time? The average time is 5 minutes. I don't know whether it's an average or median. Whether it be average or median, again, you don't know the range. You understand what I'm saying? Maybe some only have 1 or 2 minutes, because 5 minutes is the median or average. So how much time each patient gets, we don't know. The problem we know is that you need to allow a patient to get the service he needs. This is what I'm saying. No matter what the manpower situation is, you have to work towards this direction or indicator, or else it's just a lot of hot air. Whether it be 190,000, 200,000, or 210,000, you need to help the situation by trying to lower the number. I think I have almost used up the time. Do you have time for a response? Well, yes, quality is important. I agree. It is not just quantity. We like to do the best we can for each case, despite the constraints. But we need to learn, and we need to improve the system by improving manpower, and we need to understand the needs of the users. As I said, we have just started. The service has been here only for 3 years. But figures are also important. It's better to have figures, not to have figures. Just now, the figure is for reference only. It is about waiting for a new case to be attended to. Deputy Chairman, thank you, Chairman. Many members have mentioned very crucial issues. But I like to look at the structure for service provision. I like to say where improvements can be made. I think this structure is quite good. It looks good. But how can you make sure that what you design or set out to do can really be implemented? First, manpower is one thing, and secondly, the case managers or community nurses and ICCMWs, and also the consumers. These are the 3 stakeholders. My question is, well, the HA was quite modest, saying that this is a new service. It has been with us only for 3 years. You will commission a university to do the review. But you have heard the view saying, how do you regard a case as a case? And how can you involve your partners, including community views and also the consumers? You say you commission a university to do it. Will the review also take on board the views of these people? If case management is only about medication, and if you are only managing a patient, meaning that you send him into a hospital if there is a crisis, then that will be quite disappointing. And can you think out of the box by taking a developmental view? Say, through case management, you can build a relationship of mutual trust So you take care of the patient at a close distance so he can build relationships again and integrate into society and even find a job. This is what rehabilitated persons want to have. But if case management is really about crisis management and whether the patient is going to hurt others, then that's very passive and backward. Okay, you have just started and you are willing to make improvements, and if you still are working on it and you have resources, then please take on board all these aspirations. Whether or not you can accomplish something, at least you admit that you have heard the voices of the service users. Of course, you can set indicators and targets, and then caseworkers and case managers would become just writers. Now, you have to be careful about that interaction. I hope you can speak on that. And secondly, the structure. You say there is a communication platform in the middle of that process. But we have heard from a deputation that at the front line, PCP and ICCMWs never really talk, and cases only flow in one direction. Unless there is duplication, it seems there is little room for cooperation. I think district synergy leaves a lot to be desired now. You must allow community workers to have that confidence that they are working with a team. But I can't see that commitment. You say there should be a two-way communication, there should be cooperation, but I can't see that happening. Number 3, manpower ratio and premises. Some ICCMWs said that even if there is a breakthrough in terms of policy by the SWD that they can rent shopping mall premises, and the management company of the malls would say you can only use this as an office, but if you interview rehabilitated persons, you are not acting in compliance with the tenancy. In other words, you can only have the workers there, not the patients. Now, of course, the area itself is also a constraint. There are 5 which do not have premises yet, and 1 is under consultation. Are we talking about the new towns, Zhangguanou and Maonshan? They do not have street shops. And also the PRH have been sold out, so you can't find premises. Are these the districts? Please be quick. 3 questions. When we do the review, we'll certainly talk to stakeholders, including patients and the related organizations. We will involve them to see whether we have achieved the original purpose. Secondly, many members and deputations have said whether case management is really about crisis management or medication only. I can definitely say no. Case management does look at the medical, social, and family needs of the patient. But of course, we are going to do even better later. And number 3, different districts have a different development history, and they have a different timetable of developing the service. So it is not that everything is the same. Together with the SWD, we are writing out a framework on case management for mental patients involving the HA, SWD, and other organizations. We are writing that document now, and hopefully we can review the operation of the clusters, so there will be a central-led system. And in the interim, we are going to look at the differences amongst the districts. The hardware, SWD. Thank you, Mr. Tang. About renting commercial premises, we have rented 9, 4 of which are used as offices, and the remaining 5 are service points. The second question is that in Tseung Kwan O South, Tsuen Wan, North District, Mongkok, and Eastern District, we are still looking out for premises. And if there are problems with certain commercial premises, we'll support them to move away. Yes, tenancies may have different clauses, but if there is a problem, we will allow them and in fact encourage them to go elsewhere. That's it for the first round, except myself. It's now my turn. I am a little schizophrenic now, sitting in the middle of this room. On the one hand, as I said, you seem to be painting a rather good-looking picture, but on the other hand, we see a lot of problems. I'd like to mention the principles referred to by Dr. Tsuen. You say mental illness is always complicated, and patients need interdepartmental, interdisciplinary care. We have about 46,000 SMIs, but case management now covers only about 10,000 or 40% of them. Not even half, in other words. Moreover, we have others with emotional problems, including depression. These people are not helped by case management. Okay, the situation is complex. You also talked about a continuum of care. It's not just for a year or two. It should be for long term. That's a consensus. But it's clear that according to the deputations, case management would span over just 1 to 2 years. Is it that those cases have been referred to the ICCMWs? According to your paper, you are handling over 10,000 cases, but in the past few years you have only referred 700 odd to ICCMWs. Not even 10%, in other words. Why so little cooperation? If you say there is seamless cooperation, if it is interdepartmental, interorganizational, and interdisciplinary, but the response on the ground is ICCMWs cannot turn patients back to you. So who calls the shot? Let ICCMWs refer the more serious cases back to the PCP, because PCP is referring less than 10% of cases to ICCMWs. How is cooperation done? We have had the service on both sides for 3 years. Have you had one meeting bringing together all ICCMWs, PCP, and also service users? Have you got one such meeting? The 24 teams plus the 15 districts, have they been brought together to sit down and talk? And of course we have to involve the users as well. I find this rather strange. You say there is a 3-tier structure, a seamless structure, but when we really talk about it, the two sides are telling us very different things. And even the hardware, the manpower side, you are not catching up with the demand. So my question for you is, both of you do case management, ICCMWs and also DHA. Who manages whom? You have case management because the needs are complex and the service system is also complex. Therefore, you want to have one point of management, meaning there is a case manager doing coordination. In other words, it should be cross-medical, social, and other services. But it seems the two systems are doing their own case management. there is no blueprint helping patients at different stages. I am really muddled after this discussion.
To Dr. Zhang, first of all, I hope members understand that case management, the relationship between the case management and ICC-MW is not only a phase. It's not the case that if the PCB doesn't want to work on the case, they will refer it to the ICC-MW. It's not really the case, but rather they supplement each other. The 700-odd cases may not really be about the cooperation between the two sides. The patient at the same time requires medical treatment and community support. So they therefore need services from both sources, and such services could be arranged for them. So the two therefore are supplementary. It's not really, that once referral is made, it's the end of the case. And secondly, we talk about a three-tier structure, and we constantly have meetings. Dr. Zhang asked whether or not we have meetings involving the users. Well, the answer as to that is not. For the three-tier structure, in our meetings, we do not have the users. You're talking about the mental patients. How can we involve the users? Perhaps we can talk to the subcommittee further about that possibility. And thirdly, we're talking about interdepartmental and cross-sectoral cooperation. Different stakeholders have their own responsibilities. So we need coordination to ensure that the needs of the patients can be met and that support could be provided by the different units. It's not a question as who is making the decision, but rather we're talking about a seamless, coordination, providing coordinated service. The overall assessment of the need of the patient is done being collectively. I still don't quite understand, but anyway, we don't have too much time. So we may now go to the second round. Mr. Chen Kwok-chi, Chairman, I also like to go back to the topic of case management. Mr. Chen Kwok-shing told us that his expectation of case management is that other than the rehabilitated patients who need to take medication, they need to integrate with the community, and that they will need to be accepted by their own community and the families. And secondly, they will be able to take up employment in the community or further the studies so that they can lead the life of a normal person again. From this perspective, the case manager cannot just manage his medication compliance and monitor whether or not his condition will deteriorate. He should provide him with whole person support. The HA adopts the case management model, but I think they are focusing on case managers instead. The ICC-MW do not call it case management in dealing with these cases, but it would appear that they are doing the work of case management. Anyway, when the rehabilitated patients go to the center, the staff there will look after, them in terms of the work, the relationship with the family, and so on. We'll discuss with the patient all these things. So I think one seems to be doing the work of the other. It is a pity, and I understand that for the ICC-MW, I think the staff there can approach the family of the patients, but it's not counted as. But the time they spend in this area will not count as the part of the work. So why? I think, Dr. Zhang, you may as well tell us that case management only means ensuring medication compliance. If the patients have other aspirations, then they can go to the ICC-MW, so that the patients will not have these different expectations and don't know to whom they should get a service. Dr. Zhang, I've already said that it's not just about taking medicine. I've already said that that is not the case. We just not just monitor whether they take medicine and whether the conditions have deteriorated, but rather the case manager will find out about the condition of the patient and his family, and when he has any need, then we'll work with the SWD to provide the needed service to the patient. Of course, the SWD will further assess his needs for other community services. Chairman, of course, Dr. Tsuen could certainly say this, but in reality, colleagues at the PCP will only focus on asking the patient whether they're taking medicine. If the patient wants more service, the case event, the PCP will say, well, they can go to the ICCMW, which can help them. So how can you ensure that both sides are working together to manage the case? I mean, is that how you should deploy your resources? I think if you ask me, there must be one staff working as the case manager, and this person will coordinate everything that the service users need, including employment, studies, and so on. So both sides should offer a whole person support. I think we work on a joint collaboration framework. For complex cases, we have case conference to discuss what are the patient's needs and how do we arrange for that, those needs to be met. So are there any cases where both sides are working on? Yes, but they're not doing the same thing. Of course, on the medical side, the case manager will mobilize the HA system to help. When there are issues about communication, community rehabilitation, the SWD will, mobilize its own resources to do that. And the assessment is about the division of labor. So there should be a joint assessment about the needs of the patient. This is to avoid any gaps or duplications from taking place. For a simple case, the case manager and the ICCMW will have a dialogue. For complex cases, then they will need to convene a case conference to discuss the case. And this is how we cooperate at the moment. Mr. Fong. As Dr. Tsuen said, we are now working out our plans through consultation and case conferences. Our social workers very often will need to make referrals. Whatever role you play, whether you're a case worker or a case manager, if the rehabilitated patients require any service, we have a duty to make the referral for them. I also like to add that as far as visiting the family of the patient, I don't have the information offhand, but I understand that we do count the outreach, the visit by outreaching teams. The ICCMW focuses a lot on such visits. Unless the patient lives alone, if he lives with the family, our staff will already have spent some time doing this already. Well, regarding the framework document, Dr. Tsuen told us that it will describe how the HA system and the SW system can collaborate. When will that be available? We will take 6 months to draft that blueprint. I haven't seen the first draft yet, but I believe that in a month or two the first draft will be available, and we will then work on this together with the SWD. As to when the document will be available to the public, we need to go through there for several stages. We first of all have to finish the draft with the SWD, and then we need to consult with our colleagues and our medical team. They will give us further inputs to further perfect that framework. I believe by the end of 2014 it should be completed. I hope that when you have that draft ready, you would also conduct a public consultation so that the profession and all the stakeholders, including the service users, can be involved, so that we can help enrich your blueprint. the reality tell us that sometimes both sides work on a case, and after 1 or 2 years they will put it aside at the same time. And so some people who have the need may not get a service. Some are being served by both sides. So if two sides are working on the same case, we really appreciate the seamless cooperation. I believe that we have today a preliminary discussion, whether it's the HA or the SWD, the ICC-MW and the case management system has been implemented for 3 years. I think it's time for us to sit down and have a review. The service providers, namely the two systems, the systems of the HA and the SWD, the NGOs and the service users. If even today we still cannot sit down and discuss what are the flaws in the system and how we can better collaborate and cooperate, then perhaps this is time for us to do it. Even at this stage, who should be taking the lead? Should it be the HA or the Labour and Welfare Bureau or the SWD? I don't know, because in your 3-tier structure, both sides are taking charge. So it's a joint effort. Okay, could you spearhead such a discussion? We don't have too much time. And regarding the manpower situation, I understand that it's a complex issue. So regarding the case managers and the number of cases per case manager, the ratio 1 to 50 is too high. Even for the SWD, 1 to 40 odd cases. And Mr. Chung already mentioned that sometimes the number is larger than that. If the ratio is 1 to 50 for the HA, the NGO's ratio will certainly be even higher. I see the some deputations are nodding their heads. So you really need to address the issue of manpower shortage. Regarding premises, Mr. Fong said that 3 years ago, the SWD really, made a determined effort to proceed with this ICC-MW scheme. I understand that you're working hard. You put in a lot of hard effort, and I hope that through this council and also our colleagues can help promote this at the district and community level, and also in terms of community education and educate the public not to discriminate against the rehabilitated mental patients. If there's anything we can help, we will be. We hope that we'll be able to play a role in this platform. When your paper is available, that is a framework document. I hope you would invite all the stakeholders to participate so that later on we can have a review. So with that, I'd like to thank all the deputations for coming, and we may now wrap up our discussion on this item. Date of the next meeting is the 24th of March in the afternoon. I think we've changed the schedule today. And we're sorry for that.
下次我哋再呢4個內容，咁咧就可以呢個如果掂到係少少嘢都係啊，可以呢個係同埋雙辣椒都有冇錯冇錯。